Well, good afternoon, ladies and gentlemen, and a warm welcome from the magnificent Cape Town. As I look out the window over here, I can't see a cloud in the sky. All I can see is my colleague, Steve Jeffrey. Professor Jeffrey is our co-presenter. My name is Peter de Jong. I'm the co-host. And this afternoon, we fabulously privileged to have with us how to assess placental function and why it matters in clinical practice. This is presented by Professor Mushi Matjila, as you can see on your slides over there. He's the professor and head, the Department of Obstetrics and Gynecology at the University of Cape Town. As I look out the window, Steve, I can actually see the University of Cape Town and Groote Hospital from the Chris Barnard Memorial Hospital window. Professor Mushi Matjila is a person no better qualified than anybody else to present this because he has a PhD from the University of Edinburgh, and the supervisor was the illustrious Professor Leslie Regan. And Professor, just to say, she's going to be with us at SASOG. Steve, are you coming to present at SASOG? That's going to be in August in Cape Town. So I'd like to invite you all on behalf of SASOG to be with us over there, and we're going to be hearing Steve's presentation as well. Steve?
Yeah, something of note is that Mushi was in receipt of the Hamilton Narkey Fellowship Award. Do you know Hamilton Narkey?
I know exactly. Well, I mean, you couldn't hardly be at the Chris Barnard Hospital and not know who Hamilton Narkey was. Well, it's actually used as a car park, but it's actually a square called the Hamilton Narkey Square, and that's right outside over here.
Yeah.
Steve, who was Hamilton Narkey? I'll tell you if you don't know.
He was the cleaner in the lab that Chris Barnard was busy practicing his heart transplants on dogs. And he started giving Chris Barnard advice on how to do it as he was watching, because he started to assist in theatre. And then ultimately, Chris Barnard let him have a go at one of the heart transplants in the dogs, and he started to actually do the operations. And he became a very active part of the surgical team in the practicing the research on the hearts. And then, in Chris Barnard's own words, he was better than him because he went on to the liver transplant program and started to do the liver transplants, which is something that Chris Barnard was never able to do.
No.
So Chris Barnard was very impressed by this chap.
Yep.
And I think that I don't know if you know more of the story, Mushi, than that.
Yeah, and he started off as a gardener and at UCT, and ended up being very technically gifted in doing these operations. Yeah.
Okay, Mushi, we better get going now. I don't want to get into trouble. I got into trouble last week. So without further waste of time, thank you so much for how to assess placental function and why it really matters in clinical practice. Professor Matjila.
Now, we will take questions during the presentation, but we will no longer be entertaining any more anonymous questions from today on. Please put your name down when you do want to ask a question.
Makes it much more interesting as well. Thanks, Mushi.
Yeah, thank you very much. I wish to thank both of you for extending the invitation to talk on the Pelvic Floor Society meeting. Very good friends as well as colleagues, Professor Jeffrey and Dr. Dio. So thank you very much indeed for the invitation. Now, the how to assess placental function and why it matters in clinical practice. I'm sorry, I'm gonna disappoint you somewhat in the talk, because the talk, I gather, there are lots of clinicians on board, but it has to undergo a certain level of basic science for you to understand why placental function is what it is, without telling you much. So the talk outline is placental history, why study the placenta, placentation from implantation, the placenta anatomy, structure and function, assessing placental function, the tools that we use in clinical practice, placental dysfunction, disorders of deep placentation. Summary and conclusion, I'll talk a bit about Hamlet and the African Placental Network. So
that's not the movie, Mushi.
Hamlet.
It's a movie. I went to see.
Quite apart from its Shakespearean intonation. So Hamlet is actually Human African Placental Network, which is a group that we, myself and Nadia Ikumi, started in Cape Town. It's all aspects of molecular research to do with the placenta. So it's a group there. I'll refer you to it after the talk.
Okay, thank you.
So the history of the placenta. The placenta is quite interesting actually, and its earliest date of the earliest sculpture I've gotten to is this one that I'm highlighting here, and it's in Egypt. Along the Nile River. They found this in the 1800s. And you can see there is a king, there's a pharaoh, and there is 4 subjects at the bottom there holding poles. And the 4th one here, I don't know if you can see my pointer, but the 4th
Yeah,
one.
we can see the pointer. Thank you. Yeah.
Yeah, the 4th one here is actually, you can see a bilobe structure on top of the pole, and that is actually the first, what is thought to be the first image of the placenta and artwork, and it was thought to be important, and that's why it's close to the pharaoh here, about the soul and governing the soul of the pharaoh. So it's quite an interesting history, but as you read through it. It's got different meanings as you go through time. But also, you get placenta, people who ingest their placenta. I wouldn't advise it. But, I found this book with easy and delicious recipes for cooking the placenta.
Is that human placenta? Human placenta.
Human placenta, yeah. So there are individuals who actually ingest the human placenta, and on the right you can see a placental steak there, and
And I see the author. Go back, Mushi. This is the last question. I'm going to shut up after this. By a guy called Robin Cook. So
yes,
aptly mentioned.
Robin Cook. So I don't know how to go back, but
Go forward.
Yeah, I don't know how to go back. Robin Cook is quite interesting. The author is Robin Cook, but it's actually yeah, somewhat to do with the cooking, I guess, but it is. And then also there's this whole concept. A few years ago, Mail and Guardian contacted me to talk about this placental ingestion story, that the people who are ingesting their own placenta, and on the right there, you can even find capsule. It's called placental encapsulation, and people ingest the placenta, and the benefits are thought to be, just I don't know of the benefits, but it's taken from other prey, because what other animals do is that they eat their placenta so that they are not attacked. So some individuals have gone on to literally take that to confer benefits of ingesting the placenta. So like I said, it's not something that I would recommend. So why study the placenta? So it underlies the pathophysiology of many pregnancy-related pathology: preeclampsia, IUGR, recurrent pregnancy loss, preterm birth, and stillbirth, and the potential for discovery of novel therapeutic agents and targets is therefore very pertinent in studying the placenta. And there's a lot that we don't know about the placenta. But further, it adds to our understanding and improved ART technology, because if you think about it, embryonal development is just a few days upstream of placentation. So understanding embryo decidual crosstalk is very important. And again, if you do IVF, probably 30, if you're like a 40% conception rate and take-home baby rate. And so what about the 70% and 60% that isn't there? I think part of the reason is that we poorly understand this process, particularly from a human perspective. We understand very well from the rodent perspective, but not human. And advancement in IRT techniques can lead to improve outcomes such as conception rate, reduction in miscarriage rate, and take-home baby rate. All right, so again, there are the novel intervention and drug targets for hormonal and non-hormonal implantation prevention. So I know the Gates Foundation is quite interested in the non-hormonal implantation prevention as a form of contraception. But importantly, if you look at the leading cause of death in South Africa and elsewhere in the world, is non-communicable. So it's diabetes and so on. So a better understanding of the DOHAT, the developmental origin of health and disease, is quite important, or known as placental programming. In other words, the rest of your life is determined by the first 9 months of your life in utero. And that's part of placental programming as proposed by David Barker from Southampton. So potential intervention aimed at prevention of late onset non-communicable disease such as diabetes and cardiovascular disease is quite lucrative. And there you go, the paper by Barker of how the process of placentation affects the diseases later on in life. Quite an interesting read. Yeah, so I'll move on. I don't know if there are any questions.
Oh, no, you carry on. If there are, we'll interrupt. Thanks, Mushi.
Okay, and then from implantation, as I say, implantation happens a few days prior to early placental events, and you will see what I mean by that. And this is written by Errol Norwitz, who happened to be an honorary professor at the University of Cape Town.
It was also my registrar as well.
Yeah, that's right. So
Him and Mike Balfour. Carry on.
Good friend and colleague. And so you can see there in the cartoon, there is a blastocyst and there is the endometrial lining, and that is called apposition of the embryo. And you've got pinopodes, what are known as pinopodes on the endometrial layer, and microvilli there. But there's a whole lot of signaling that's happening around. That controls this implantation, that controls the implantation window of the endometrium. So things like LIF, which is leukemia inflammatory factor, and EGF signaling, and other hormones, estrogen and progesterone, are important in setting the scene for a receptive endometrium, so that implantation can happen. So that's about 9 to 10 days after conception. And so now you see it's gone into the decidual lining or endometrial lining, but we call it decidua in pregnancy. And there you can see the early formation of the cytotrophoblast and the syncytiotrophoblast on the outside, which is the early placental formations. And it's governed mainly by oxygen tension, but also a whole host of factors that control that process. And then further on is much more developed. You can see here the syncytiotrophoblast and the cytotrophoblast forming. And so you can see that there's a whole host of hormones, endometrial factors, cytokine growth factors, immunological factors, which I won't talk about, but it's a whole talk on its own, and enzymes produced by the trophoblast. So if you think about it, there is the placenta forming, is producing HCG. HCG is maintaining the corpus luteum, which produces progesterone, which maintains the decidua, and the decidua and the glands of the decidua are the early food of the conceptus. So there is no vascular development at this stage. The food for the developing conceptus is the growth factors and secretions in the endometrial glands. So I very much think of the placenta as like a broccoli. So I apologize to those who enjoy broccoli, but there are very much similarities. And you can see there that will be the maternal factor with all the syncytotrophoblast villi, and that will be the stem villi and the terminal villi there. That's what I'm talking about, the stem villas and the terminal villas. The terminal villas is supposed to exchange gas, and on the outside of it, if you blow that up, you'll see that on the outside it is syncytotrophoblast. On the inside is the cytotrophoblast layer of the placenta, which is the placental stem cell, if you like. And blown up here is what it looks like. The intravenous space in pink is the maternal blood, and these fingers here in cross section are your terminal villas, and they contain on the outside layer cytotrophoblast, inside layer cytotrophoblast stem cell, and the villus capillaries where exchange happens. So that's just a photograph of what it actually looks like. This is one of our patients, and the yellow is the fetal vessels, and the green here happens to be kisspeptin. That's how it looks like in real life. And so again, that's how exchange happens. There is no exchange of blood. They are fetal vessels, and but they are in close opposition to the maternal vasculature. So if you look at the villus stem cell, which I've said is a cytotrophoblast, it can either go the villus trophoblast pathway or the extravillus trophoblast way. If it goes through the extravillus trophoblast cell pathway, it will form endovascular trophoblast, which is a trophoblast which infiltrates the spiral arteries, and interstitial trophoblast, which is in between. And this is the most important aspect of what trophoblast does. So these are cytotrophoblast columns, and there's interstitial trophoblast there in green. You can see they're in between the villi. This again from our patient. And this is intramural trophoblast. It's infiltrated into the vascular wall of the spiral artery. So that's actually a spiral artery there. The orange there is trophoblast cells. So the whole point of this cells and their invasion and the extravillus trophoblast is to transform the vessels. So I like this statement because it's so true. It was true then. It was written in the 50s, and it's still true today. The integrity of the conceptus of man must depend directly upon the provision and maintenance of an adequate maternal blood supply to the intervillus space, which I showed you was in pink there. Until we understand how the supply provided and maintained throughout all the changes in the maternal hemodynamics accompanying uterine, placental, and fetal growth, we are likely to comprehend little of the physiological interrelation between mother and fetus, and even less placental pathology. And so I can say that with confidence, that the statement, I quite often look to it and look back on it for so many years, but it's true. We don't quite understand the dynamics behind the physiological changes of pregnancy. So here is the anatomy, but I won't bore you. Just to show you the spiral arteries, here is the endometrial lumen, here is the outside, and you can see that they are the branch of the radial artery, which are a branch of the arcuate arteries. So transformation of maternal spiral artery is important. And that's what trophoblast cells do. They transform the vessels. So from what was very narrow vessels with thick walls to below the line there, which are much more flaccid. They have lost their smooth muscle component, as you can see. And they're governed by a law called Poiseuille's law, which determines that small changes in the radius equate to large changes in flow. So small changes in the radius of the vessels confer large changes in the flow of blood that provides for the conceptus. And there you can see an unremodeled spiral artery with all the muscles and the trophoblast infiltrated, as I showed you earlier on. And the changes in the radius is huge. And it's important because you find two components of the spiral arteries. You find the decidual spiral arteries and the myometrial, which are in the inner third of the endometrium. And you can see that it's changes in preeclampsia. If you use preeclampsia as a model, you see that it changes to the myometrial component of the spiral arteries. That's important. And that component is known as defective tip placentation. And as a result of that, you get less blood flow through the placenta in untransformed spiral arteries, hypoxia as a result of that, and the release of circulatory factors such as SFLT1 and placental growth factor that can be measured in circulation. Just to mention, there's also something called fetal trafficking or trophoblast deportation, which mainly means that the syncytium now and then breaks off into the maternal circulation. It's part of normal pregnancy, and that's why you can measure things like cell-free DNA in the maternal circulation because you've got syncytial trophoblast debris circulating through the maternal circulation. And syncytial trophoblast debris is quite normal. It happens in normal pregnancy, but when exaggerated, it activates an immune response in response to the excessive trophoblast debris and as in preeclampsia. So all these relief factors in circulation cause systemic endothelial dysfunction that result in hypertension from endothelial control of vascular tone is lost, proteinuria, and edema. There's a loss of vascular permeability, coagulopathy, and systemic endothelial dysfunction in various organs. And that's why preeclampsia is such a multi-system disorder. And so you get poor placentation, to summarize, placental oxidative stress from untransformed spiral arteries, less blood flow through the placenta, spewing of material into the maternal vasculature or the intervillous space, maternal inflammatory response, and clinical signs of preeclampsia. So defective deep placentation explains some phenotypes of preeclampsia intrauterine growth restriction, idiopathic pregnancy loss, spontaneous preterm birth, and placental abruption are all heterogeneous, but they share a common source. And really, it's a syndrome. So when you talk about placental dysfunction, you're talking about a range of disorders, as you'll realize. So the great obstetric syndromes are associated with disorders of deep placentation. So as I highlighted, is the myometrial component of the spiral artery that remains untransformed, and that leads to problems. And so if you look at preterm labor, preterm rupture of membranes, IUGR, you get, and you oppose that to myometrial spiral artery remodeling. You'll see that in those conditions, the spatial remodeling of the artery, where there's complete absence of the condition, you get preeclampsia, and absent with obstructive lesion, you get preeclampsia with IUGR, abruptio placenta, and placental infarct. All these are part of one syndrome, and that is the defective deep placentation disorders. But the placenta is also is not passive. Okay, so glucose, for example, is one of the fuels that the placenta uses, and it's transported by certain glucose transporters, as GLUT1 to GLUT12, and then in different areas of the placenta, and performing different functions of glucose transfer. But also, it's also an endocrine organ. It produces things like HCG, as mentioned earlier on, progesterone, estradiol, human placental lactogen, leptin, adiponectin, PAPA, placental protein 13, activin A, inhibin A, kisspeptin. So it's an organ. It's also performing endocrine function. Like I said, I want to even talk about the immunological aspect of things, because it will make this talk far much longer than it will be. Suffice to say that it performs many different functions, and those functions tend to be modulated with gestation. So at 13 weeks, it may perform certain functions. At 20 weeks, it may perform different functions. At 35 weeks, it may perform far more different functions. So when you talk about placental function, necessarily you are not talking about the flow disorders that we pick up clinically. You're talking about a dysfunction in, for example, one of the transporters not working properly. So in cases of IUGR, you may find that you've got one or two or three dysfunctional enzymes or transporter enzymes that and as a result, there's a nutritional defect on the side of the baby. That's not necessarily because of vascular flow dynamics. That's because of an inherent defect in the enzyme that transports that. There are not only enzymes that process glucose, but there are enzymes that process lipids, amino acids, and so on. So when you talk about placental function or dysfunction, you talk about something wider than we are clinically used to. And as I said, disorders of deplacentation include miscarriage, preeclampsia. Preeclampsia is a model most studied, IUGR, preterm delivery, gestational diabetes, and stillbirth. And we know that stillbirth, most of stillbirth, this country has got a problem with stillbirth. I mean, we're sitting at 22 per 1,000 births of stillbirth, whereas the goal as part of the SDGs is at 12. So we almost double that target. So I'll use preeclampsia briefly as an example of placental assessment, and I'll make a case for how we can assess placental function using preeclampsia as a model. So if you look at preeclampsia, and what we do is that we take a history, and then based on the history, we risk assess whether the patient is high risk or moderate risk. And it's because of all those factors previous. Preeclampsia is one of the strongest ones, but chronic kidney disease and so on, to assess risk. And that was part of the NICE guidance. So you assess as high risk if there are those factors. You'd assess as moderate risk if you have those factors. But the truth is, it will predict only about 30 to 40% of patients who eventually develop preeclampsia. So you miss out the majority of patients who will eventually develop preeclampsia. This also illustrates the same point. Major risk factors and other risk factors, you can see the relative risks there are listed, and you can only predict 30 to 40% based on those factors of those who will develop preeclampsia. For example, in this country, we know that primigravida are most at risk of maternal death related to preeclampsia, yet they don't have any prior history of most of them of the conditions that are listed here. So you miss you miss quite a number. So these are the maternal characteristics that determine the a priori risk on the Fetal Medicine Foundation assessment tool, and there are those you can see, and so I will compare those of NICE guidance, for example, that I showed earlier on, that if you to detect early onset preeclampsia, you actually are not further off in predicting the development of preeclampsia. You can see there, if you are nulliparous, if you are parous, at best 50%, at best 55%, and so on. So the detection rate is quite poor based on the history, but it gets modified somewhat using the fetal the maternal foundation tool of just taking the history alone. So you see it's about 30 to 40%, as I've said. That's just taking maternal characteristics and medical history into account. Okay. So, but if you take accurately the history and you take the mean arterial pressure accurately and properly, you can then somewhat improve that. And as illustrated in this cartoon, so mean history alone is about higher. Mean arterial pressure alone is a bit lower in the prediction. But if you take the maternal history and mean arterial pressure combined, you get somewhat of an improved outcome. So what we did, we are part of the PEARL study, and the PEARL study is a collaborative preeclampsia African study to look at Ghana, Kenya, and South Africa. And using history, which is what we do, we could only predict 40% of those who develop preeclampsia. But we used the modified fetal-maternal foundation tool, which is a risk assessment tool, and you can see that in all African countries that improved to 62%. That's unpublished. There's data as of last week, and it just highlights the point that if you take a proper history and you do a mean arterial pressure, measure blood pressure properly, you are able to predict a bit higher. So I'm going to show you the same thing. So if you take maternal risk factors, the detection rate is about 40%. If you add mean arterial pressure, it improves somewhat to 50%. If you then add uterine ultrapositivity index, you will then improve it to 68%. And if you add PAPA to it, which is a biomarker and a blood-based biomarker to assess placental function, to 68%. And if you add PLGF instead of PAPA, you much improve that to 74%, and the area under the curve is 91%. There's no benefit if you're doing PLGF in adding PAPA because it doesn't improve the outcome. So it just shows you the different options. And the screening for preeclampsia takes the route that actually of understanding placental function, and also combining with maternal factors such as cardiovascular factors and so on to give you a risk prediction for preeclampsia. And the risk prediction is useful because it gives you an individualized risk for development of preeclampsia. I just thought I will share with you what is happening in the world. So that cartoon represents the kind of imaging for preterm labor, preeclampsia, and IUGR, because they're all placental dysfunction disorders, and the tools that are used to detect them. So the majority, you can see, is now going into biomarker testing, and these largely are as a result of analyzing the placenta, and they are produced by the placenta. 14 is as a result of imaging, so uterine artery Dopplers, in particular, to predict disease. The umbilical artery Dopplers you use to diagnose disease, not necessarily to predict it. And you will see that it's multi-parametric test, which means triangulating information from the imaging and the biomarkers to give you a risk profile. That's about 16 of those, and 9 are other tests. So with much progress in preeclampsia biomarker research, novel biomarker-based tests have been developed to aid the diagnosis of preeclampsia. While biomarker research is promising, it is unlikely that a robust diagnostic test will rely on an individual biomarkers. which explains the importance of biomarker tests as multi-parametric tests. And it makes sense. It's a multifactorial disorder, and each pathway, there are so many pathways involved in preeclampsia, will be represented by a biomarker, which then is useful in calculating and predicting the disease. So this is one of the images taken from the FIGO group, and you can see they are proposing the way to go ahead and screen your population. So they firstly they proposed a two-stage model. The first stage screening with maternal factors and mean arterial pressure alone, as we did within the studies with Kenya and Ghana, and then either some will screen negative and some will screen positive. Of those who screen positive, then you do uterine artery Dopplers and placental growth factor to sort out the population. So that is one proposal that they have. The other proposal, of course, is to do everything. Maternal characteristics and medical history, mean arterial pressure, placental growth factor, plus uterine artery pulsatility index. And that gives you a composite risk assessment much earlier in pregnancy, where you can risk assess where the patients need to fall. And again, I would like to stress, this is not only a risk assessment for preeclampsia, it's a risk assessment for placental dysfunction. So it takes care of spontaneous preterm birth, IUGR, stillbirth, and so on. So it's not just for preeclampsia, but it's for placental dysfunction disorders. And therefore, you can then set your threshold for low or high risk, and that you can determine based on your resources. So here they propose less than 1 in 100 or more than 1 in 100 to let those patients go to retained care or to give them aspirin. And that's much earlier in pregnancy, 11 to 13 weeks. This is for fetal growth restriction. And again, the factors for fetal growth restriction, just to illustrate the point, are the same risk factors as for preeclampsia, if you look at them. And so chemical markers there are low PLGF, low PAPA, and high alpha fetoprotein, and imaging is uterine artery Dopplers, which are high, bilateral notching of the arteries, and so on. So these are pretty much similar to what you find at preeclampsia, but it's no surprise because they are placental dysfunction disorders. So the recommendation for fetal growth restriction is a detailed history, detailed sonographic assessment to exclude soft markers and sonographic sign related to fetal infection. Dopplers include at least umbilical arteries, uterine arteries, and middle cerebral arteries Dopplers, and maternal screening for relevant congenital infections. Okay, and they just make a point that the extent of innovation may be limited, of investigation may be limited by available resources. So the human placenta and its role in reproductive outcomes, you can see there the disorders of deep placentation, preeclampsia, fetal growth restriction, spontaneous preterm birth, gestational diabetes, stillbirth, and the tools that you may be, as it stands, we use uterine artery Dopplers to screen much earlier in pregnancy, preferably, and umbilical artery Dopplers to diagnose the condition. But you also have blood-based biomarkers, and now the studies are gone beyond to include genetics, metabolomics, proteomics, single cell RNA, and so on. And of course, placental histopathology. And yeah, so those are the sort of proposed intervention. And so there are a lot of pathological entities. The molecular lesions in the placenta involve upregulator of apoptosis, oxidative stress, cellular senescence, and so on. So these produce a small placenta or a globular thickened placenta, thin umbilical cord, and so on. But the thing that you may use include biomarkers as well as imaging. A combination of biomarkers and imaging, reduced PAPA and HCG, and reduced PLGF. So in summary, the placenta is a complex organ with many functions. The functions change with increasing gestation. Placental dysfunction covers not only flow abnormalities, because clinically we detect flow abnormalities and we assign that, well, there's flow abnormalities, so therefore there is placental dysfunction. That may be true, but the spectrum of placental dysfunction is much wider than it is. It involves many functional perturbation, as I've mentioned, placental transport proteins involving glucose, amino acids, lipids, and so on. But also there's immunological abnormalities, HLA-G, for example, and various other factors that modulate immune tolerance to the conceptors. But these we are not able to detect clinically as of yet, but they are factors in producing dysfunction. And it will only take advances in imaging technology, of better ultrasound, of perhaps other units are using studies, but in countries are using MRI to better understand these things, nuclear physics to understand the biology and the metabolome of the placenta. So it's a combination of imaging technology and biomarker assessments, certainly PAPA, certainly PLGF, and others that are candidates in there. So I would like to finish off by mentioning the Human African Molecular Placental Research Platform, which is HAMLET. Our vision is towards a better understanding of placental science with the aim of improving maternal and perinatal health. Our mission is to contribute towards a mechanistic understanding of placental biology and utilization of placental biomarkers to improve outcomes associated with placental-mediated disease, assisted reproductive technology, and long-term maternal and child health. And so that's what we do, embryo-decidual crosstalk in the periconception and understanding that better, recurrent miscarriage, preeclampsia, early onset in particular, idiopathic preterm birth, intrauterine growth restriction, gestational diabetes, the disorders of deplacentation, and assisted reproductive technology. So I've got a partner in crime. She's a placental immunologist trained in Harvard, but is from Kenya. She's my partner in this, and we've got all clinical and lab staff, and so on. That's our website at UCT. And just recently, about 2 months ago, Dr. Ikumi has launched the African Placental Research Network. I'm also part of that network to try and bring together all placental interested scientists and clinicians in a network that that advances placental science. So we hold regular webinars, just like this one, and we aim also to capacity develop with regards to placental science in Africa. So if you want to be part of it, just share or just Google African Placental Research Network, and that will take you to the site. So thank you very much. I don't know if you have gone over time, but
No, we haven't.
thank you for listening.
Mushi, thank you very much indeed. Steve's going to thank you. I just want to bring up some of the questions that have come our way. There's a clinical question. You mentioned earlier on in the talk defective deplacentation, which causes that list of abnormalities that you listed, and disorders of deplacentation, which causes similar. Is there any way of preventing defective deplacentation in some way to improve clinical outcomes?
Yeah. So certainly aspirin so we know aspirin from the many trials that have been conducted that if you administer aspirin, but you have to administer it early in pregnancy. The earlier you administer it in pregnancy, the higher a chance that you will be successful in preventing preeclampsia, especially unanswered preeclampsia in the index pregnancy. But preterm delivery, especially spontaneous preterm birth, has now been a candidate in which aspirin may. Some of the earlier studies are showing that aspirin in idiopathic, I'm stressing, preterm birth may have a role. And in recurrent miscarriage cycles, progesterone has not been shown to be effective, as evidenced by the PROMISE trial, but a sub-study of the PROMISE trial that of higher order pregnancies, so miscarriage 4 or upwards, may benefit from progesterone early on in pregnancy, especially if they manifest with bleeding. So there are interventions, and there are interventions that we can test, but we need to be able to understand. It mustn't just be a hit, a fishing expedition in terms of what we're trying to do. We must understand the pathophysiology, which would be placental in as much as possible. And in that way, we may have a chance to prevent this disease. So I think it's preventable, but you have to intervene earlier.
Okay. How early
Because
is early is the question. How many weeks?
yeah, so I would argue theoretically, I would argue a theoretical and a clinical answer. Clinically before at 11 to 13 weeks, but within the research, we must explore even giving some of the products periconception, because the placentation starts with a very good decidual window. that decidual window is affected by things like progesterone, VEGF receptors, VEGF-A, and so on. So if you aim to improve it, I would say studies must explore the possibility of administering this intervention earlier, and what's earlier? Preconception. But that's within the realm of research. Practically, I would say at 11 to 13 weeks, because that's when the placental vasculature is just established. So we know that the placenta in the first trimester develops under hypoxic conditions. So, and that we know because the spiral arteries are plugged until after 9-10 weeks when they become unplugged, and therefore the oxygen tension also rises after that period. So I would think the target should be
10
yeah.
weeks.
Yeah.
Okay. Here's another question. Elmarie Besson says, when should you do your test for Papa? What gestational age? How many weeks?
Okay. Also, earlier, 11 to 13 weeks, you should do your
Okay.
Papa to risk assess.
Okay.
And as I demonstrated with the figure on one of the figure charts, so it's very important that it's not just the test. So you have to take a very good history. You have to make a very good clinical assessment, and then there's a role for mean arterial pressure. There's a role for uterine artery Dopplers, and then there's a role for biomarker testing.
Okay.
So I think for risk assessment early on in pregnancy, and depending on how you want to risk assess the patient, and then allocate to the right resource. Because part of our challenges as a country is that we've got a lot of wrong patients in an overwhelmed system. So we need a way to, I think, from a public health perspective, to properly risk assess patient earlier on in pregnancy, and then allocate to the appropriate levels of care. So
Thank you.
yeah.
So one last provocative question before Steve thanks you. You've persuaded us that aspirin's a wonderful drug, a real panacea. Why can't we give it to all pregnant women from 10 weeks onwards?
Yeah, so it's a good question, but aspirin is not without its side effects, and chief amongst those are bleeding in pregnancy is a real risk factor, and I can tell you that the dose question of aspirin, 75 milligram versus 81 versus 150 milligrams, is not as clear. I know our guidance says 150 milligrams of aspirin in those who are assigned high risk for pregnancy, but it is not sorted out. I think you need a randomized control trial to sort it out. I know that there is plans to do because of the risk, to do a study that looks into administration of aspirin much earlier and stopping much earlier. So right now, people stop at 34 to 36 weeks of aspirin. But if you had to argue, its main role is to modulate and affect placentation, right? Then you would argue that you would administer it early and it would have done its purpose. It would have performed its purpose in terms of modulating placentation, and therefore you stop it much earlier. So the study is to look at 24, starting it 13 weeks, stopping at 24 weeks, precisely to some of the reason is to obviate the risk of the adverse effect. So you cannot administer it to everybody.
Okay. Thanks, Steve.
Great. Yeah. Well, thanks, Mushi. It's been wonderful to really just highlight just the the role of the placenta and how arguably the most complicated and complex challenges we face in obstetrics today are still lying at the root of the placenta. And I think you guys who are taking these initiatives to research this and try and get to the bottom of it are really maybe at the holy grail of the complex stuff: preeclampsia, growth restriction, unknown stillbirths, etc. So congratulations on everything you've done over the last 30 years on the placenta. But we look forward to some real progress now
We
that
do.
you guys are collaborating with each other.
Yep.
And yeah, so keep up the good work. We're quite proud of what you've done so far. And thanks for the talk as well. We really appreciate it. I think you've shown us that there are some glimmers of light on the horizon with some of these things, especially in the detection of the issues. But we're looking forward to some better therapies as well for
Yep,
these
we
particular
certainly
things.
are.
And I think maybe with some new technologies, we could, maybe see some change in preeclampsia and those really complex
Yep.
things. But anyway, thanks so much. And thanks everyone for joining.
Thanks
And
to
thanks to
Chris.
Pete. Yeah, thanks to
Thank,
Chris.
and,
Yeah.
and we love your picture, Mushi. No one's ever mentioned. There's a picture of your farm, isn't it? So it's a beautiful picture of your farm. That just slipped in, and no one actually saw it apart from me. And yeah, it's a beautiful farm. Next time we must go and have a braai there.
No, it's not my farm at all. It's not my farm at all. It's the Golden Gate in the Free State.
Well,
As you
No,
that doesn't look like anywhere in the
that
Western
looks
Cape.
like Napier.
No,
He's
that's
got a
No,
farm.
no, it's not Napier. It's not Napier. It's the Free State.
But why the Free State? But what's the significance?
Because I travel the Free State. It's such a beautiful province. It's a beautiful province, and it's got
Yeah.
beaches like this.
Yeah.
So this is just
No, it's
outside.
just a general picture. Okay, Mushi, thanks very much.
Thanks, everyone.
We're gonna hear you talk on hypertension one of these days, God willing, please God. And to all those people that logged on, thanks very much. Safe home, Steve.
Thank you. You too,
And
Pete.
now Steve won't be with us. He's going to be in Azerbaijan as the keynote speaker next week. He's giving 6
Where?
speeches in Azerbaijan, which is
Where's that?
it's Mushi. Azerbaijan's is in Asia, Central Asia.
Oh,
Isn't that
okay.
right?
Yeah, it's on the border of Iran.
Iran. Oh gosh.
Oh,
I hope you
okay.
get back safely. Iran.
You must be a brave man.
It's nuts. Okay, Steve,
Thank
and
you.
all of us, good
All right,
night.
cool.
Safe
Travel
home.
safely.
Thank you.
Safe
Bye-bye.
back, Steve.
Okay, thank
Okay,
you.
all the
Bye.
best. See
Bye.
you. Bye. Bye-bye.
Bye.
Bye. Bye.